Nearly 25% of all cancer metastases migrate to the liver. Left untreated, this disease progression drops a patient's median survival to 6 months. Yet with targeted intervention, that 5-year survival rate can reach 58%. This reversal is possible because of two specific biological properties: the liver's unique vascular architecture and its regenerative potential. The first of these mechanisms is the liver's dual blood supply. This hepatic lobule diagram illustrates normal flow. The blue portal vein supplies 80% of the volume to healthy hepatocytes. But metastatic tumors behave differently. Hijacking the hepatic artery, they draw their entire blood supply from this red arterial source, leaving the portal network untouched. Before targeting this arterial connection, pathologists must identify exactly what tissue has invaded the liver. By testing the biopsy for specific immunohistochemical biomarkers like CK19 and CK20 for adenocarcinomas, or S100 for malignant melanomas, they pinpoint the exact anatomical origin of the invading cells. This arterial hijacking provides the biological access required for loco-regional intervention. It gives interventionalists a direct pipeline to deliver lethal payloads specifically to tumor cells, while the portal vein safely sustains the healthy host liver. The liver's extreme capacity for regenerative hypertrophy establishes surgical resection as the gold standard for treating anatomically viable tumors. In hepatic surgery, long-term success is determined by the exact volume and baseline health of the tissue left behind, the future liver remnant, or FLR, rather than the total volume of tumor removed. This 3D model shows a healthy liver. As long as the vascular supply and biliary drainage remain intact, surgeons can remove up to 80% of the total mass. The remaining 20% segment will rapidly hypertrophy, expanding back to restore full baseline volume and function within weeks. If the patient's liver suffers from mild to moderate dysfunction, such as steatohepatitis caused by prior chemotherapy, the organ's regenerative capacity is blunted, requiring a minimum FLR of 30% to survive. For patients with heavy fibrotic scarring from hepatic cirrhosis, the constraints are tighter. To prevent acute liver failure post-surgery, a strict 40% functional remnant is required. Achieving these volumes often means operating close to the tumor. Wide anatomical margins are unnecessary. As long as there is a microscopically negative margin of just 1 millimeter, patients achieve equivalent long-term survival. When a patient's baseline tumor burden leaves an FLR too small for immediate surgery, oncologists can deploy portal vein embolization. By intentionally blocking the portal flow to the diseased side, they force the healthy contralateral side to hypertrophy, increasing the patient's FLR before the resection begins. Surgical oncology in the liver is an exercise in volumetric math. The surgeon must balance total tumor eradication against the strict mathematical minimums of functional parenchyma. When a patient is medically or surgically inoperable, physicians turn to transarterial radioembolization, or TARE. This internal approach directly uses the hijacked arterial supply to destroy the tumor from within. TARE relies on the specific radiological physics of yttrium-90 glass microspheres. These particles are pure beta emitters with a short half-life of 64.2 hours and a maximum tissue penetration depth of approximately 1 centimeter. These precise physical constraints allow the microspheres to inflict localized, massive radiation damage deep within the tumor while providing a rapid dose fall-off that protects the adjacent healthy liver tissue. To execute this safely, medical physicists rely on a rigorous dosimetric formula. This equation calculates the exact radioactive activity of theraspheres required to achieve a lethal 120 Gray target dose within the tumor. In this equation, the variable m represents the required mass calculation of the patient's entire liver, measured in kilograms. The variable s represents the lung-liver shunt fraction. Because microscopic vascular abnormalities can allow spheres to bypass the hepatic bed, physicians must map this pathway pre-treatment. They inject technetium-99m labeled albumin and track its dispersion using a SPECT scan to see how much material escapes into the lungs. If the shunting fraction is too high, the treatment is aborted. Patients are disqualified if their total bilirubin exceeds 2 milligrams per deciliter, if their lung shunting is greater than 20%, or if the projected radiation dose to the lungs from a single application equals or exceeds 30 Gray. Ultimately, tear is an unforgiving physics equation. A miscalculated Schutten fraction causes the microspheres to bypass the hepatic bed and lodge in the pulmonary system. This leads to fatal collateral radiation damage. For patients with oligometastatic disease, typically fewer than 5 liver metastases, physicians can deploy thermal ablation. By generating localized temperatures exceeding 60 degrees Celsius, this technique induces absolute coagulative necrosis, destroying the cell membrane and denaturing tumor proteins. One method is radiofrequency ablation, or RFA. This involves passing an alternating electrical current at frequencies between 375 and 500 kHz through the targeted tissue. The rapid alternating current generates heat through intense ionic friction. But RFA has a critical anatomical failure point, the heat sink effect. If the tumor sits near a large flowing blood vessel, that vessel acts as a thermodynamic drain. It pulls thermal energy away from the ablation zone, leaving the edges of the tumor cool and untreated. To overcome this localized cooling vulnerability, interventional radiologists utilize microwave ablation. Instead of friction, microwave ablation utilizes high electromagnetic frequencies, ranging from 0.915 to 2.45 GHz. This induces dielectric hysteresis, rapidly flipping water molecules. This method achieves higher intratumoral temperatures, uniformly radiating heat through the entire mass and overwhelming the cooling pull of adjacent vessels. Both RFA and MWA share a strict geometrical limitation. To achieve optimal local control, target tumors must be smaller than 3 centimeters in diameter. When a tumor exceeds that 3 centimeter boundary, the statistical success rate drops. Local control falls from 85% down to 39%. Selecting the correct thermal ablation tool requires mapping the tumor's anatomical proximity to major vascular structures. The physician must determine whether generating heat via ionic friction or dielectric hysteresis is thermodynamically viable for that specific location. Another non-invasive option for medically inoperable patients is stereotactic body radiotherapy, or SBRT. This technique uses external linear accelerators to deliver ablative, highly conformal radiation directly to the metastasis. The primary anatomical challenge of SBRT is that the liver is in constant motion. Because the organ rises and falls with every respiratory cycle, radiation oncologists must use 4D CT respiratory gating, or precise abdominal compression, to track and isolate the moving target. Pinpointing the tumor is necessary to meet the strict dose constraints set by the NCCN and the AAPM. Exceeding these thresholds risks triggering radiation-induced liver disease, a potentially fatal complication. This dose-volume histogram illustrates the exact safety threshold. In a 3-fraction SBRT course, over 700 cubic centimeters of normal liver must receive less than 15 gray. While healthy tissue is spared, the dosimetric target for tumor eradication requires a biological equivalent dose exceeding 100 gray. Navigating these converging constraints requires an interprofessional tumor board. Medical oncologists, interventional radiologists, and surgical oncologists must operate in precise alignment. Long-term survival depends on aligning exact physical and biological limits, pacing neoadjuvant systemic chemotherapy, calculating the FLR surgical math, measuring the target-to-lung shunt physics, and hitting that 100 gray threshold. Extending a 6-month terminal prognosis into years of survival is an exercise in applied mathematics and exact thermodynamics. Transitioning the patient to a curative path requires this shift to a precise, data-driven discipline.